Lord Rama, as we have recently had Ram Navami, thought of singing a small song on Lord Rama. So today I'll be the MC, I'll be the moderator, I'll be the singer.
All in one.
So
You are
kindly bear
singing?
with me.
You are singing now?
Yes, sir.
Okay.
1 minute of my song, sir.
Yeah. Okay.
Yeah. శ్రీరామ పాదమ నీ కృప జాలునే శ్రీరామ పాదమ నీ కృప జాలునే తీర్థానికి రవే ఏ శ్రీరామ పాదమ నీ కృప జాలునే వారిజ భావా సనక సనందన నారదాను లెల్ల పూజించే శ్రీరామ పాదమా నీ కృప జాలుని దారుణీ శిలయై తాపము తాళక వారము కన్నీరును రాల్చగా సూరహల్యను చూచి బ్రాచిన రీతి ధన్యోషేయ వీర త్యాగరాజ గేయమ శ్రీరామ పాదమని కృప జాలునే. Thank you. So after we seek the blessings of Lord Rama, in the honor of Endometriosis Awareness Month, we are turning our focus towards one of the most challenging and technically demanding phenotypes of this disease, that is urological endometriosis. So now I would like to introduce our chairperson, Dr. Vijay Kumar, chairperson of Urogynec Committee, and Secretary BSOG, to introduce Dr. Durgadas sir and take over the proceedings.
Good evening to all. Today we are having a very interesting topic, the urinary tract endometriosis. As you all know that there is about 1 to 5% of the incidence of urinary tract endometriosis. This is like just a tip of the iceberg. Most of the time, the urinary tract endometriosis goes unnoticed. The commonest organ involved is the bladder, but it may also affect the ureter and rarely the kidneys. The symptoms varies from cyclical hematuria to just a vague pain abdomen. So as we all know that the principles of the surgical principle of endometriosis is excision of the endometriotic spot. The challenge in urinary tract endometriosis is that we have to encounter the vital structures. So today we shall discuss the diagnosis and the management of the endometriosis. I welcome our President, Dr. Durgadas sir, for this webinar. I also welcome Shobha Gudi madam, the Secretary of KSOGA. I also welcome the Treasurer of the KSOGA. And we have the eminent speakers as the panelists. Along with me, I have Dr. B. Ramesh, who is a known figure in the minimal invasive surgery. And we have a upcoming the robotic surgeon, Dr. Rohit Ranade. I welcome you all, and I request our President, Dr. Durgadas sir, to say a few words about today's webinar.
Shobha Gudi, Secretary first.
Yes, sir.
First our mother.
I invite Shobha Gudi madam
Yeah,
And I
thank you,
request
Vijay.
Madam to say a few
Yeah.
words.
Yes, few words only, Vijay.
No, madam.
Of course.
This is just
No,
a
because
formality.
yeah, because we don't want repetitions, right? We want the experts to start speaking. But I am delighted that you were able to, bring together this event because the month is going to end, and this is a month for endometriosis awareness. And a lot of progress needs to be made in this field as far as implementation of the guidelines is concerned, and relief to women who are suffering chronically with endometriosis. Still a lot of lacunae in their care still remains, and many of the times women cannot afford the treatment which has emerged lately in terms of medication, and probably surgery still remains as an option. And it is wonderful that we are having two very eminent surgeons in the field. My dear friend Dr. B. Ramesh and past president of Bangalore Society, I have heard him speak on this subject earlier also, and of course his experience in this is very rich, and I am delighted that you have brought him today onto the platform for KSOGA. Thank you, Vijay, for that. And even Rohit, I have known him as a robotic surgeon, so I think today he will also bring perspectives for treatment of endometriosis. So I welcome to all KSOGians. I wish more and more people will join these webinars. And over to the dynamic chairperson Vijay and his very able secretary Aarti Sridhar to take this forward. Over to Dr. Durgadas for his words. Thank you very much. Thank you.
Good evening, everybody. At the outset, I congratulate Dr. Vijay Kumar and his team for this excellent um, talk. First of all, the uniqueness of your CM is always you start with the live invocation song. It was very melodious, the Arati. It's really welcoming. We are all playing the recordings, whereas it's the only committee we are hearing the live invocation song.
Thank you, sir.
Coming to Vijay Kumar, you have given all the unique programs you have given. This is Ramesh. This is my last. I'm finishing my presidency of KSOGA by
Oh,
this month. But this
okay.
month and 17th, handing over my charges.
But
So
very well done,
yeah,
especially
yeah.
KSOGA on subsequent
Thank you,
conferences.
thank you so much. And I should congratulate Vijay Kumar. Every time he has come out with some unique program. Today also, your urological aspects of endometriosis, something unique. And what stalwarts of speakers you have chosen. Dr. Ramesh is a good friend of mine. We are proud of him being Karnataka product, and he's a national, not even national, he's an international fame lab surgeon. We are proud of him, and you could get him today. And Rohit, upcoming robotic surgeon, KSOGA welcomes you and wishes you a bright future. I don't want to take much
Thank you.
time. All the best to the program. And Vijay Kumar, more and more laurels to cap henceforth. Thank you for the programs. Thank you.
Thank you, sir. Thank you, sir. At the outset, I would like to thank KSOGA team for giving me this opportunity. And now we dive into the world of deep infiltrating endometriosis. To guide us through this frozen territory, we have a panel of stalwarts who operate daily at the intersection of gynecology, urology, and various fields. Our goal today is to move past the simple excision and master the art of functional preservation. So today we have expert panelists like B. Ramesh, Dr. Rohit Ranade sir, and Dr. Vijay Kumar sir. So Arun, can you please show their CVs? Arun? So Dr. B. Ramesh sir doesn't require any introduction at all. So he is the clinical and academic impact worldwide, his leadership roles, his professional associations, his conference and workshop participation, his surgical expertise cannot be, accomplished at all. So he has done more than 100,000 major gynecological laparoscopic surgeries and continues to excel in this field. He's a visiting gynec lab surgeon at numerous hospitals, and he has various awards like Lifetime Achievement Award by BSOG 2025, Legendary Award by IAG 2024, Dronacharya Award by ISA 24, Karnataka Rajyotsava Award by 2011, Aryabhatta Award, National Award 2011. So the next CV, please. And our beloved Vijay Kumar sir doesn't require any introduction at all. He's the professor and head. He was the professor and head at Ambedkar Medical College. Now he is at Akash Medical College. He is the secretary for BSOG and also the chairperson, Urogynec Committee, KSOGA. The next slide, please. So today we have Dr. Rohit Rande, who has done his fellowship in laparoscopic and robotic gynec surgery and a fellowship in peritoneal surface oncology. He is a senior consultant and clinical lead at Narayana Health City, Bengaluru. He is specialist in gynec oncology, laparoscopy, and robotic gynec surgery and peritoneal surface oncology. So we shall start the panel
Yes,
discussion.
Dr. Aditi.
Yes.
We shall move to the...
Yeah. Arun, can you please share the slides?
I request Ramesh sir to be more open for this panel discussion. Whenever he wants to intervene, he can intervene because all the delegates are looking forward for the input from the Ramesh sir.
Yeah.
And
No, it is a mutual discussion. Yeah.
So today's topic is Beyond Pelvic Pain, Unveiling the Urological Impact of Endometriosis, a panel discussion. Next slide. So I'll be giving few clinical scenarios and then we will go ahead with few questions, and in between I think we'll have interesting video presentations also by Ramesh sir. So the first case is a 34-year-old nulliparous woman presents with severe dysmenorrhea, cyclical dysuria, and urgency, occasional hematuria during menses. Ultrasound shows a lesion on the bladder dome. Next slide. So the questions are open to the panelists. The first question is, what is your differential diagnosis for cyclical hematuria in reproductive age women?
Anybody can answer?
Yes, sir. Please give your input, sir.
Yeah. See, I think differential diagnosis of cyclical hematuria, many times it may not be hematuria, because the menstrual blood is coming in the urine. So we have to rule out that cause. I think that is the most frequent cause patients come with blood in the urine at the time of, that is because everything is mixed up. So that history we have to take and do the examination and all. And of course, endometriosis is an important diagnosis of cyclical hematuria. And also, any bladder symptoms can get worsened during the menstruation because of increased vascularity and congestion. So we cannot rule out, we cannot just blindly say that it is bladder endometriosis unless we investigate. So these are all it may be stones, it may be malignancy, though typically not, but anything is possible.
I think what Dr. Ramesh sir has said is absolutely correct. Majority of the times, this typical history is given by very few people. Most of the times they will present with hematuria. More or less, they will present to the urologist first, then coming to the gynec, unless somebody has severe dysmenorrhea and also associated with it. But as sir has rightly said, we have to rule out other causes of hematuria before zeroing out to endometriosis as the cause. But this typical history, the bleeding or the lesion becoming more prominent during menses, is something which should not be ignored.
Yeah. Actually, when we actually see, sir, this the hematuria, usually if there is any the serosal involvement or muscular involvement, then the hematuria may not be that significant. But I feel if there is mucosal involvement of the bladder or the ureter, then it becomes the significant hematuria. And I often see, sir, most of the women, they will be coming with acute urinary tract infection. In such cases also, they will come with the hematuria. So the either the differential diagnosis we can give is the urinary tract endometriosis. But before that, the most common, the urinary tract infection, that too acute, the cystitis. And apart from that, even sometimes the patient may get confused. So we should also check if we ask them to collect the urine during menstruation, definitely there will be contamination. So we have to ask them to properly collect the urine. That is also very significant. Otherwise, we may get confused. So these are some of the differential diagnosis. Apart from that, even severe vaginitis during menstruation, that is either with the trichomonas, such infection will also lead to the cystitis, leading to the hematuria. So all these things has to be kept in mind.
Yes, sir. I think, like all of you rightly said, since it is cyclical hematuria, the bladder or ureteral endometriosis would be our first diagnosis. And rarely, as like sir said, it can be carcinoma. So the next question would be, how do you distinguish bladder endometriosis from interstitial cystitis clinically and radiologically? What is the role of cystoscopy versus MRI in this case? So both questions can be taken together.
I
Investigation,
think
how do you?
clinically, interstitial cystitis as a typical history that it need not happen always during the periods, right? And bladder endometriosis, most often it presents during the periods, or it may overlap also. And interstitial cystitis, the maximum symptoms are seen with full bladder. When the bladder is full, you will see the acute pain. And patient typically, they say, like the pain is like cutting with the blade. So that typical explanation I have heard from the patient, sir, it feels like cutting with a blade. And all the time burning, burning, burning. Whereas endometriosis, it need not be that kind of pain. And bladder endometriosis, of course, if she is taking any painkiller or anything, the bladder endometriosis may get some relief, whereas interstitial cystitis, so usually there is no relief with any medication. And these are all the clinical examination, and of course, any associated evidence of any other compartment endometriosis. And radiologically, difficult to differentiate between interstitial cystitis or bladder endometriosis. If there is a nodule or lesion, we can, but interstitial cystitis requires cystoscopy for diagnosis. You cannot diagnose bladder and interstitial cystitis on with the MRI or ultrasound. It is very difficult. You need cystoscopy. See, any of these urological problems, cystoscopy is the easiest way to find out, rather than doing MRI and confusing the patient. And first of all, I don't believe any of these MRI reports.
Dr. Ram?
No, yeah. So, I mean, sir has rightly said, according to history, it would differentiate. Sometimes it can be a retrospective diagnosis. Like, for example, patient has a cyclical hematuria, goes to the urologist. Urologists their threshold, as sir has said, for doing a cystoscopy is very low. The first investigation that they would do a cystoscopy. A cystoscopy can differentiate between an interstitial cystitis and an endometriosis if there is a nodule, typical appearance of a nodule. And MRI, I mean, unless there is a nodule of a significant size, it's very difficult to differentiate. If it is like a plaque, or then it's very difficult. But if it's a significant nodule, then MR usually is quite sensitive for diagnosing a bladder nodule. But obviously, cystoscopy is like the gold standard.
And ultrasound is quite sensitive for bladder endometriosis, unlike other types of this thing, because the bladder is filled with urine and you can see the projections, nodule projection. And many times, like we need to see the ultrasound is good enough. So I think ultrasound, if it is not clear, why do you want to do MRI? You do cystoscopy only.
Actually, both the problems are chronic in nature. So usually the patient will not come in with the history of a few days of these problems. There will be a long-standing history, and quite distinctively, the endometriosis will be coming with the complaint of cyclical hematuria or cyclical problem. She may tell that only in these few days of the month I will be having, the rest of the days I will be fine. Whereas interstitial cystitis is a continuous, whether it's day or night, the patient will be having the three symptoms, that is the urgency, urge incontinence, and increased frequency. So as previous speaker said, the interstitial cystitis we can make out very clearly in the cystoscopy with a lot of trabeculae, grade 3 trabeculations. And the confirmation of interstitial cystitis would be the cystourethrogram. That is the most distinctive. Nowadays, because of the good advancement in the ultrasound itself will be able to identify some lesions on the bladder wall. But if there is mucosal involvement, definitely the cystoscopy is significant. The one more advantage of cystoscopy is that unlike in the ultrasound, cystoscopy will be easy to demonstrate any endometriotic minimal spots also. If suppose if there is 4 or 5 millimeter spot, which will be difficult by ultrasound to detect, cystoscopy it will be very easy
and
very evident.
cystoscopy ideally in interstitial cystitis, the diagnostic criteria or the diagnostic thing is when you distend the bladder with cystoscopy fluid and collapse it, it will start bleeding. Hemorrhagic spots will be seen all over. So whereas if it is endometriosis, it will be confined only to one area.
Yeah, the small petechiae is seen in.
So petechial hemorrhage, that too you may not see it directly when you do the cystoscopy. You distend the bladder and empty the bladder so that it will collapse, negative pressure, and all these spots will have a minute bleeding, reddish spots like. So that is diagnostic of this thing.
Yes.
Interstitial cystitis.
Sir, to know the depth of invasion or any extravesical disease, would you like to go ahead with an MRI before proceeding with any kind of therapy, or you're happy with this?
Happy with the ultrasound and cystoscopy. Cystoscopy is the gold standard. MRI is not conclusive. It is again confusing. So ultrasound, if you suspect something, or history-wise, if you are suspecting something, do cystoscopy. And these things, hysteroscopy and cystoscopy, should be available in the OPD. The biggest problem is, take them to the OT, which becomes a very big procedure. So where you keep your transvaginal ultrasound, you should have one small cystoscope and hysteroscope also, which acts both. And within 1 minute, you can diagnose. So rather than doing all these things.
If you have to see any extravesical disease, sir, if you are suspecting.
Extravesical disease?
Yes, sir.
In cystoscopy.
If you have to see.
MRI,
suppose,
on MRI.
No, sir. In this particular case, she is with
Of course. MRI, if you confirm that there is a bladder nodule,
Okay.
Nodule, of course, it needs complete evaluation like MRI, because there the MRI and an ultrasound, it can be assessed very well. Because the difference is, though
Oh,
it is said that the endometriosis is outside in disease, it
okay.
comes from in the peritoneum inside, but many times there could be isolated mucosal bladder endometriosis. So many
Okay.
times, if when you put laparoscope, bladder, peritoneum, and everything is normal, I have
Mm.
seen cases like that where only mucosa is involved. So in
Okay.
those cases, it may not be required to do all these things. But
Okay.
where it is involving the bladder wall, to know the details, you can do that.
Okay.
Yeah,
MRI.
I would do an MRI in all cases. I would slightly differ from Dr. Ramesh. Uh, uh, primarily because I believe MRI images you can see yourself more better. So, as endometriosis is most of the times it's an outside in disease, though there are cases where there can be an isolated like a drop meds. I mean, like somebody has a disease in the pelvis, the bladder wall is all normal, and there is a disease inside. But an MR is more accurate in terms of where is the involvement. Also, whether it is with a good radiologist, you can also know whether it is supratrigonal or infratrigonal. Though cystoscopy would be confirmatory, and we would not proceed for surgery before doing a cystoscopy. And as sir has rightly said, I think we should be very, very lenient, or our threshold for doing cystoscopy should be quite low. It's something which should always be done before planning surgery, because you need to know where is the, if the endometriotic nodule is there, where is the extent of the nodule, whether it is supratrigonal or infratrigonal, what wall is it likely to involve. And there, I think a correlation between MRI and cystoscopy is definitely used.
Yes.
Yeah,
Yes, sir.
actually, I just wanted to add one more point. Although Dr. Arati has asked a very specific question, I just want to extend my the one more diagnostic tool would be the CT urography. This is also quite important because it will also tell about the excretory system of the kidneys, which is also very important. So, what I have seen, and in the even the literature mentions, most of the time the kidney function would have come down because of the chronic the ureteric obstruction. So all these things and the site of the lesion and the extent of the ureteric stenosis, all these things can be very well understood with the CT urography as well.
Absolutely.
So apart from cystoscopy, MRI, and the other investigations, a thought of the CT urography will be quite essential.
Yes. Yes, sir. That's
Yes,
a
yes.
valid input, sir. Thank you. So, in this particular case, would you proceed with a medical therapy first or a primary surgery, and for what reason?
See, the medical therapy is not really indicated because bladder endometriosis means it is surgery only. So whether it is just mucosal or intramural involving the bladder wall. Suppose if it is a only mucosal, and if you are sure of this, and away from the ureteric orifices and trigone, so you can do this transurethral resection of that lesion, though it is like because to make it less invasive, if you are very sure that the wall is not involved, that can be done. But if the bladder wall is involved, definitely surgery is the first treatment of choice. And probably after surgery, you do medical suppression for some time because these microscopic deposits we cannot excise. And the recurrence could be there even in bladder endometriosis after the surgery. So we would like to suppress with the progesterones or GnRH analogs for some time, so that the recurrence rate can be reduced. And medical therapy, what you will do, like it is not a trial therapy or anything, because you are directly seeing and deciding, unless like primary dysmenorrhea, where you try OC pills, and now also nobody does that trial. So I think that should not be done.
Yeah,
Yes.
primarily, I mean, I may be wrong, but I haven't seen an isolated bladder endometriosis without there being any disease in the pelvis. Most of the times there will be some disease in the pelvis, and most of the times surgery is the treatment of choice. It's very less likely that they will respond only to medical management, unlike a specific scenario where there is only a small mucosal. But I haven't seen such a case. I mean, it's always a combined. You have
90%
yeah
of the 90% of the bladder endometriosis is always
with
associated with other
pelvic disease.
compartments.
Yes,
There is no doubt about it. Of course, along with that. So, but I am telling only about isolated bladder
yes,
endometriosis,
absolutely.
where like mucosa or only the muscularis layer is involved, and absolutely rest, especially in cases of previous section, it is possible that there is a contamination at the time of the cesarean, or maybe metastatic also, lymphatic spread or hematogenous, where only the mucosa is involved. So one of the gynecologists was suffering so much from this thing, and she was reluctant to undergo cystoscopy. Then I put her on GnRH. She got relief. Then we did cystoscopy, and that it was only mucosal this thing which was excised.
Yes, sir. So, if at all now we have decided we are going for surgery, so what are the surgical principles when excising the bladder endometriosis? How do we proceed with this?
So I think bladder endometriosis, so depending on the extent, as I mentioned, so it may be in the location of the bladder endometriosis or nodule is very, very important. And many times it is in the fundus, especially after the cesarean. So when it is in the fundus, the treatment is very easy. Fill the bladder and excise the nodule. Wide excision has to be done, not just there is no question of fear or anything here. Do wide excision, partial, almost amounting to partial cystectomy, but always check that you are away from the ureters, and suture the bladder in 2 layers. So that will do. And if it is very close to the ureteric orifice, you have to do the stenting of the ureters and do the excision. So these are the surgical principles, and the wider excision is the most important thing. Don't just do the excision of the nodule. Wide excision and post-operative long-term suppression to reduce the recurrence.
Yeah, so I think that is where the point which Dr. Vijay Kumar made regarding the CT urography is also important. It depends on what is the location of the nodule. Sometimes it may be involving the ureteric orifice, and some part of the distal ureter may also be involved. So in that case, you may have to go for a distal ureteric excision and then reimplanting the ureter along with a cystectomy. That is all. And principles, like sir has already said, wide excision, and in closure, it should be always be a 2-layer tension-free closure, and then you can keep catheter for a longer period of time. We usually keep it for 10 to 14 days.
And another important thing is when we close the bladder in 2 layers, we can use barbed suture, but not for the first layer,
First layer.
mucosal layer, because that barbs can produce urinary stones in the means within 6 months to 1 year. So first layer, what you can do is you can use 20 or 30 Vicryl, and second layer you can close with barbed suture. So this we must remember. Whereas bowel, nothing happens. Both the layers you can close with barbed suture. But in bladder, the first layer has to be delayed absorbable like Vicryl. Second layer could be this barbed suture.
Yeah, actually, the very two important things is one is the site of the lesion, very important. As previous speakers said, the management will entirely differ with the site. If it is close to the ureter, again, ureteroneocystotomy has to be done because then only we can conclude with complete excision. If it is on the dome, you should be very happy that you will be able to deal only with the bladder wall. And as the principles of endometriosis is the complete excision of the lesion. That's very important, as previous speaker said. The one thing apart from this is what is the suture material we use. Even I have seen, sir, the Vicryl which we use, if there is any involvement of the bladder mucosa, definitely stone formation will happen. That's what I have seen, because it will take about 60 to 70 days for it to completely absorb. So
You should
what I
use
have modified
Lambert
is,
suture. You should
Yeah.
not involve the mucosa.
yes, sir.
Both bladder and bowel, we have to take Lambert sutures so that the mucosa is not taken.
Yes, sir. Yeah, I was about to mention the same, that better to exclude the mucosa and concentrate on the detrusor muscle. So the mucosal closure will be, it will take about just 24 to 48 hours for the epithelium to form. So, and it will not cause much problem, and it will be leak proof, even though we don't include the mucosa in the suture material. But definitely, as previous speaker said, two-layer closure is very important. If you are affordable, the barb suture or else 20 polydioxone
Can I
Yeah.
show the
or
video of the
polygalactine.
partial? I think I will show the video so
Yes,
Yes,
that
sir. Please,
we
sir.
can
yes, sir.
explain better.
So
Just
another till the time just Dr. Ramesh connects the video. Another what we have started using is for the inner layer we use PDS,
yeah.
which is
Ah,
slightly less reactionary than the Vicryl,
yes.
though there is no but that's what we use. We use 4 or
Do
we
you
use 3.
include
Yeah, smaller.
mucosa
Yes,
voluntarily?
yes.
Yeah.
No, sorry.
Okay.
Do you include the mucosa?
No, so now there is good data to suggest both for bowel as well as for the bladder, the strength is mainly from the submucosa so you can in fact I mean there is no need to take the mucosa. You are
Yeah.
actually doing more damage by taking the mucosa.
So this is the take-home message for the delegates. You need
So
not
can you
include
see
the
the picture,
mucosa.
Vijay?
Sir?
Yes, we can see.
Yeah, so this is a case of bladder endometriosis, which was operated in Dubai 10 years back. So this lady had previous section, and when we put the scope, we thought it was a bladder Foley's catheter. Of course, like it was looking like a Foley's. In earlier investigations were done, so a beginner may confuse this nodule with a Foley's bulb. So you can see here, as I mentioned in previous section, it is common. And so the principle of bladder surgery is the bladder should be mobilized widely. All around you mobilize from the retropubic space and the lateral walls, so that when you suture, you will be suturing without tension, and suturing becomes easier. So this is even when you are doing TLH and bladder injury is there, the first thing to be done is mobilize the bladder all around, and then take sutures. So that makes the procedure easier. So though it takes little time, it is worth spending, rather than, because many of the failures are because of the tight anastomosis and necrosis. So you mobilize the bladder, and so you can see here
Sir,
that
actually
is
the video is not playing, sir.
not
Mm,
play.
not
Why?
playing, sir.
Why is
Sure.
that? Share it.
Right. No, sir, I think
You
you
have
should click
shared the
on the
screen. You can just double click on the video.
video.
Just play it.
We can see 3 videos, sir. Whichever is the video, I think you should just double click on that.
Double click on. Play. Now is it seen?
No, sir.
No. Arey bhai. Now is it seen?
No, sir.
Oh, then stop share. I think because we are, yeah. we are seeing the other transmission. It may be difficult to see the. Anyway, at the end, I shall play all the videos.
So,
You proceed with this.
okay,
Yeah.
sir.
Yeah.
So,
So I think sir has rightly said, just wherever you are suturing anywhere, either you suture a bowel or you suture a bladder or you suture a ureter, tension-free anastomosis is more important. And that's why I think the point that he mentioned that you need to mobilize the bladder well. So whenever you are excising and then suturing, always make sure bladder is it's an organ which can be mobilized very easily. So you have to use that anatomical advantage and always mobilize. Even if you have a bowel injury, or you are doing an anastomosis, always make sure that you mobilize the bowel, and it should not be under tension. Under tension, if you suture a bowel, any suture that you use, it is going to have problem. Same is with the bladder.
And we have to do a methylene blue test at the end of the repair so that there is no leak. So it should be watertight repair so that you don't miss any leaks or anything. And
Absolutely.
also, if you have any doubt about the post-operative leak, you can put a patch of momentum on the suture line and stitch the momentum to the suture line so that it gives additional protection.
Absolutely.
yes, sir. So, any other take-home points for the surgical aspect?
So I think
And
what sir has
in this laparoscopy and role of laparoscopy or robotic surgery also, I would like to have an input, sir.
Day by day, I think most of the endometriosis surgeries are done minimal access. You can do it either laparoscopically or robotic. Robotic platform does have certain advantages like easy dexterity and the ease of use and everything is there. For suturing, it is little easier. But in the hands of a skilled laparoscopic surgeon, it may not make that difference. So it's an individual choice. You need to
There
offer
are,
the
I
patient.
think, a lot of studies comparing robotics and conventional laparoscopic surgeries. So none of these show, any advantage of robotic over laparoscopic surgery. So whether it is laparoscopy or robotic, it is a tool. So understanding the principles and your dissection. I see only the role of robotic is age, probably when you are 70 or 75-year-old. So because you are getting pain and the tremors, all that thing. So probably it is helpful. Otherwise, and also learning for training the postgraduates or beginners, it is a good tool. So, but finally, you don't bother what you are doing. So you do follow the principles of the surgery. That is most important.
Yes.
So how do you counsel regarding the recurrence and fertility? She is a young girl.
Yeah. So I think if any patient, whether young or middle aged, so like if you are planning for IVF, for example, in these cases, fertility, so she can go ahead without surgery. So you don't have to excise the bladder nodule. So unlike a posterior compartment and like uterus, etc., the bladder endometriosis does not affect the fertility. So if there is mostly nowadays, the role of surgery is in case of IVF is to improve the implantation. So first we do the pickup, freeze the embryos, and then do the surgery, even in deep infiltrating endometriosis. So bladder, so no question at all. So it all depends on the symptoms and the lesion. So for fertility, please don't do any of these bladder endometriosis.
Yes, sir. Yes, sir. So the challenge on counseling part, sir. Two to three sentences about how do we counsel?
For 2 to 3 centimeter nodule.
Yeah. No, 2 to 3
counsel means
sentences about counseling. How do we counsel the patient
2 to
about the recurrence? How do we counsel?
recurrence. See, endometriosis, we should never tell the patient, I am going to cure your endometriosis. So that is any endometriosis for that matter. The first sentence what you have to tell to the patient is there is no permanent cure for endometriosis. And you normally I compare it diabetes. So, like diabetes, you have to be on treatment, but you can lead a normal life with the treatment. But we cannot guarantee, even after hysterectomy, there is no guarantee of eradication of the endometriosis. So, you should never say, and there is always possibility of recurrence, which can be avoided to certain extent with wide excision and long-term progesterones.
Okay.
Yeah.
So long
Also,
term means 3 to 6 months, or how long, sir?
minimum
So
6
at
months.
least 6 months is
Minimum
good.
6 months. So
Minimum.
also in addition to this, when you are counseling patients, you also need to counsel them about the extent of surgery. We need to tell them that this is not like a norm. This is a slightly not complicated, you should say, but slightly more demanding surgery than what is the normal surgery. So we expect her that she will have catheter for some amount of time. We also expect the surgery to be long and her recovery to be slightly more delayed than what is expected. So that is also
Yes.
something which is important to be counseled.
Yes, sir. Thank you, sir. So we will move to the next scenario, sir. So this is a 38-year-old woman with known deep infiltrating endometriosis presenting to you with vague pelvic pain. And the imaging reveals left hydroureteronephrosis, and she has a reduced renal functions, and she has only minimal urinary symptoms. So, how do we proceed with this case, sir?
So I think she's 38-year-old and already left hydroureteronephrosis and renal function is 30% reduced. So
Yes,
I
sir.
think we have to hurry. We cannot postpone the surgery, forget about infertility, IVF, everything, because otherwise she's going to lose the kidney. Do the deep, it is a deep endometriosis, do laparoscopy, and so completely release the ureter and put the stent because already hydronephrosis is there. So though it is a external compression, so it is better to put the stent for around 8 weeks and give post-operative suppression. The problem with the urologist is they will just put the stent and run
Yeah.
away without trying to know the cause of ureteric obstruction. They don't even know why they are putting the ureteric stent. So I will tell you one of the commonest cause of renal failure in women is endometriosis. That is apart from other functional pathologies like diabetes, etc. But anatomically, endometriosis is one of the commonest cause of renal failure. And unless, so if you put just the stent for endometriosis, remove after 8 weeks, it will reform again. Obviously. So then again, patient will go for this thing. And reduced renal function is already 30%. So it is almost like a semi-emergency. We need to release the ureter and stent it and follow up with further renal function tests.
Yeah.
Yes.
I think one point which I would see most of the times, the endometriosis specialist is the last person that this patient will see. Most of the time, she will present to a urologist. A urologist most of the times would put a stent, and the stent is only going to sort of whatever the urine is coming, it will just to drain. But the actual problem is not going to get solved. The endometriosis is going to continue to worsen. It's going to block the ureter further, and she is actually lucky that she has come with a reduced function of 30%. There are some patients who come directly with non-functioning kidney, and on retrospective imaging and diagnosis, then it is found out that she has an endometriosis. And as sir has rightly said, most of the times it is a stent. The stent is already put most majority of the times, and then you do an imaging, which could either be an MRI or a CT scan, which will reveal what is the degree of hydronephrosis and what is in this. Seeing the entire course of the ureter is something which is very very important to know at what level. Most of the times, the level of obstruction is at the level of uterosacrals, where the ureter traverses through the tunnel, and that is what is going to be solved by surgery. Depending on that, then you need to counsel them for a surgery.
So, what investigations would become mandatory before intervening?
So in this case, majority of the times, she would have already undergone a CT urography from outside, or at least a CT urography. I would also do an MRI also in addition to this to see the involvement of the other pelvic structures, what degree of endometriosis he has. What I have also seen is majority of the times they are all asymptomatic. They may be they may not have much pain as well. So they may be asymptomatic as well. So that's why imaging is something which is important.
Hello?
Yeah.
Yes.
Yes, sir. Okay.
We'll go to the next question.
Yes, sir. So, would you prefer ureterolysis, reimplantation, or segmental resection?
Now, I think that depends upon the pathology. So, if there is no hydronephrosis, if it is only, see, ureterolysis is a routine step of the deep infiltrating surgery, because unless you dissect the ureter, you cannot do peritonectomy, you cannot do any further dissection. So then many times the ureteric shaving has to be done because there are nodules on the adventitia sitting on that. So we may have to dissect the nodule from the ureter. And segmental resection, when do we do is when probably the upper part of the ureter or the mid part of the ureter is involved. The lower part of the ureter is always ureteric implantation is the must. And any surgery on the ureter except ureterolysis has to be done on stenting. And whatever you do with stenting, it always heals. And as Rohit said, the commonest site is when you trace the ureter from the pelvic brim. So where it disappears underneath the uterosacral ligament or McEnroe ligament, that is the site. 90% of the times, that is the site. And other locations, it doesn't happen. So, and segmental resection is,
Very
of
common.
course. Yeah, if it is a localized segment, say on the middle part, mid pelvic ureter, so you can do the resection anastomosis. So then that is how it is to be done. And bilateral ureterolysis is compulsory in cases of all cases of deep infiltrating, because without ureteric dissection, you cannot proceed.
Vijay, sir, would
Yes.
you like
Yeah.
to say anything?
Actually, yeah, as Dr. Ramesh sir said, another important thing is that the ureteral mucosal involvement. So, ureteroscopy is quite important
Yeah.
and significant in such cases. If there is ureteral mucosal involvement, definitely segmental resection is valid.
No, and
Otherwise,
also
if there is
even without ureteroscopy, also if the wall is fibrosed, see thick and fibrosed,
yes,
so even with laparoscopy, you can decide this
yeah,
portion of the ureter has to be removed. Of course,
yes.
if you have ureteroscope, you can go ahead. But
Yeah,
most of the times,
luckily in most of the cases it will be the distal ureter, but
mm,
sometimes as even in the mid ureter also, in such a mid ureteric the lesion, definitely end-to-end anastomosis with the resection of the that segment becomes very valid. Otherwise, in the distal ureteric involvement, definitely we have a very forgiving the bladder, which we can mobilize for ureteroneocystotomy and we can manage. Otherwise, mid-ureter, definitely a lot of difficulties we had to find in mobilizing the ureter before the anastomosis.
so you have to know rather than mobilizing the ureter, of course, you have to dissect
Bladder
the
involved.
ureter till this thing. You have to mobilize the bladder
Bladder.
more, so
Yes.
that
Yeah,
it comes. And
Yes.
don't put stitch when you are doing implantation,
for
because you
distal
will have
ureter, yes, sir.
severe groin pain and severe flexion
Mm.
pain, and it is not necessary. So a stitch is
Yeah.
absolute. obsolete, because if you mobilize
Yes.
the bladder, you can take the bladder up to the pelvic brim actually,
Yes.
if you dissect
Yes. Yes.
nicely. So I think psoas should be given, because I had a very bad experience
Yeah.
that even after 6 months, the patient came with severe pain, not
Yes.
responding to anything. So I stopped doing psoas
Yeah.
procedures.
So we also had a similar experience, not in endometriosis, but in recurrent cervical cancer, where ureteric reimplant was done for a distal ureteric region. So there, the patient kept on complaining of groin pain, and now we have stopped doing we have stopped doing psoas. Instead, we call the urologist for a Bori flap in case it is difficult to mobilize the ureter more, especially in a post radiation bowel bladder. It may be difficult. So in that, a Bori flap is more better. Also, one more thing which we have recently started is, sometimes what happens is, you may not have sort of resected the ureter, but sometimes what happens, it becomes so much involved in the endometriosis that it becomes quite, you feel that it is devascularized. In that situation also, it is safe. You can check the vascularity of the ureter by injecting ICG dye, which is a new thing which is there. And in case of doubt, it is always better to resect and reimplant than to have a ureteric leak in the post-operative period.
ICG dye through the ureteric catheter.
No, sir. ICG
Through-
dye through the ureteric catheter is for identification.
Hmm.
In that case, you have to give it
Vascularity.
Yes, IV you have to give.
Okay.
Similar
15 minutes.
Yes, similar
Ah,
concentration that they give for kidney tumors. From there, it gets excreted into the ureter.
okay. Fine.
Yes, sir. So, like how this ureteric endometriosis, usually it's called the silent threat. So, how do we prevent missing this diagnosis in routine endometriosis cases?
No, just routine ultrasound can definitely identify hydronephrosis and hydroureter. And of course, when you have suspecting any ureteric problem, you can do the CTKUB. I think CTKUB is the gold standard for any ureteric problems or urinary system. And try to avoid multiple, cystogram, that gram, this gram. CTKUB is good enough for the diagnosis.
Yes,
And
sir.
on also, when it is important that when there is a significant amount of hydronephrosis, like somebody has a severe hydronephrosis, and on the CT-KUB you see that the kidney cortex is quite thin.
In
It's
the
also important. It's also important to do a DMSA or a DTPA scan to document the function of the kidney, because that
Yes.
is what you are going to decide. Because in
Whether
some
you need
cases, nephrectomy may
nephrectomy.
also be required.
So, before doing any, before proceeding to nephrectomy,
Yes, absolutely. That is an indication. It's a gold. You need to document the function of the kidney less than 10%.
yes, yes. So, so what would be the common complications you encounter when you do such surgeries? And I think post-op leak would be one of the
Yes.
Yeah,
commonest
see, I
complications.
think the commonest long-term complication, what I see, is the stricture formation. Because, if you repair anything on the stent, it will not leak. That is one thing. And ureteric implantation even doesn't have the stricture problem. So that is why, and of course, if you have any doubt, you can put a drain abdominally and this thing. So I don't foresee any, only problem is the stricture formation and maybe stent problem. Sometimes the stent may get obstructed, or removal is difficult. And what I have realized is the stent need not go up to the renal pelvis. It bypasses the anastomosis, the few centimeter above the anastomosis. That should be good enough. So sometimes we are not able to pass the stent right up to the pelvis of the kidney. So in that few centimeter above the anastomosis is sufficient, though it is not this thing. And also C-arm, I don't know why they use such a big machine for identifying the ureteric this thing. It is so cumbersome, such a big machine they will think, and you will forget that you are doing ureteric stent. Ultrasound is a beautiful this thing, and you will see a railway track
Sir's signal is so.
Yeah, sir is not audible.
Yeah. So I think as complications, sir has said, I think leak is something which is a complication which is seen. Again, there is a difference between a bowel leak and a ureteric leak. Unlike the bowel leak, which is very, very unforgiving, ureteric leak to a certain extent can be controlled. Obviously, above when you put a stent, even if there is a small leak, it will settle on its own. Unlike a bowel leak, which is quite dangerous and can have detrimental complications or side effects. Unlike the only difference is the unlike bladder, which is like a forgiving organ, the ureter is usually not a forgiving organ. Usually there will be some long-term sequelae like a stricture, which is a commonest thing, or a leak which is there. So again, as sir has said, tension-free anastomosis is something which is important. Do it over a stent. Use delayed absorbable stitch sutures for anastomosis. And always put a drain. I always put a drain, though there is, according to the ERAS protocol, you can avoid a drain, but we put a drain in all the cases. And in a situation, always anticipate a complication rather than saying that it may not occur. Like in this, ureteric leak is the first complication that may occur. So whenever the drain is increasing, always send the drain fluid create. And if you want, you can always do an imaging to find out.
Yeah.
So what about fistulas, sir? Ramesh, sir?
What is that? Fistula?
Fistula. As a post-op complications,
See,
have you ever noticed any
the
fistulas?
fistula is common when it is not recognized. When the injuries are, all the fistulas happen because of the non-recognition during the surgery. If you recognize and repair on the table, most of the times the fistula doesn't happen. And even if it happens, say, suppose you have done ureteric implantation, and there is a leak per vagina, and you think that there is a anastomotic leak, you can go back immediately and redo the surgery within 24 to 48 hours. You don't have to wait for a longer period. And one important test when she starts leaking in this is the fluid you take for creatinine levels, because you are in doubt, always doubtful whether this is a urine or vaginal discharge after such a prolonged surgery. So if you do the serum, creatinine of the fluid which is leaking, so it will be many times higher than the blood and serum creatinine level. So that will definitely is very useful. Of course, you do other investigation.
Again,
Test to identify the.
Okay. Yes, sir. Sir, would you like to show some videos, sir? We might wind up in another 5 to 10 minutes.
No, please play.
We might not go through all the questions.
Please show this.
Yeah.
You can, you can take it out.
Sir, meanwhile, would like to know any post-op management like early bladder training or any neuromodulation, anything of that kind has been required in patients who have undergone such major surgeries?
Yeah, so patients, I mean, as I said, in a situation where you have opened the bladder, resected, we always put a catheter. We always put a catheter for 10 to 14 days. If you are leaving it for 10 to 14 days, usually bladder training is not required. Previously, there was some data that you had to clamp the catheter and then remove it. But now we remove it without clamping. Usually, sometimes the stent can be irritating, and these patients may have an increased frequency of urination. Sometimes you need a muscarinic blocker may need to be given for a period of 1 month to 2 months.
Playing in my video, in my laptop, but I don't know why it is not transmitting. Is it seen now?
Yes,
we can see your screen, sir.
Aarti?
Sir, we can see your screen.
Double click on this one, sir.
Video, sir.
What is the video?
Play mode. We are seeing that.
Yes,
We are
sir.
able.
Yes, sir. You have to
Yeah.
go to the folder, sir.
Huh?
Video folder. Which one? Yes, sir.
No,
Yes, sir, we
But
are
you
able to
cannot
see.
see the video now.
Now
We
we
can
can
yes,
see
see,
the
sir.
video.
Yeah. Okay. Video folder, you go and do this, Baba. So now this is the bladder nodule, which was operated in Dubai almost 15 years back. As I mentioned, the wide mobilization of the bladder is essential. And so here you can see there is no other evidence of endometriosis. The posterior compartment is free and uterus is also free. So I think any bowel, bladder, or anywhere you are doing suturing or repair or anastomosis, the wide mobilization. So that is the most, you spend more time with the mobilization, then the anastomosis becomes easier, repair becomes easier. So you have to spend difficulty in this, you fill the bladder and open it up. So you can fill the bladder. Hey, bye. What is this? It is coming.
Yes, sir, we can see
Yeah,
the
we can
video.
see the video.
Film is coming, Vijay.
yes,
We
sir.
can.
Yes, sir. The video is clear.
Now it has stopped playing, sir.
Is the video coming there?
Yes, yes, sir, it was coming.
Yeah. Okay. Sorry for and you can see this a little bit wider because that time I was not so bold, because in Dubai sheikhs will not leave if there is any problems. So like this is how it is. So probably if it is in the fundus, you can be bindas, you can excise the whole fundus and suture it. And another problem is you can see this is a previous cesarean. The posterior bladder will be adherent to the cervix, and you should not suture without mobilizing the posterior wall. You should mobilize the posterior wall. And see, you can see here, this is the mobilization. If you just close like that, it won't be correct. So mobilize both the walls should be free, and then you do the suturing. And of course, we are away from the ureteric orifices. And I'm using barbed. That time I did not know what can happen if you use barbed as the first layer. Most often nothing happens, but as a surgical principle, so try to avoid the barbed suture in the first layer. And first layer you should not take. Here I am taking the mucosa. So the bowel and bladder, you should not take the mucosa, because sometimes there is aversion of the mucosa of the bladder and bowel, and that may be the cause of leak. So we should use this Lambert suture for bladder and bowel repair, and cover it nicely. Doesn't matter even if you repair with 3 layers. And like, don't the urologist will say, no, 1 layer is enough. Don't believe that. So it is a shortcut. And many urologists do like that and show it to others. 1 layer is enough. I am very confident. Don't do like that. At least in 2 layers should be this thing. So that is how it is. And the next video, this is the one. So it nicely she came out. And another is this is ureteral segmental resection. So where so you can see here there is a can you see the video, please?
Yes, sir.
Yeah. So this is the hydroureter and hydronephrosis. And so the ureter is exactly like how Dr. Rohit said, it is always at the level of the uterosacral where the crossing happens. And so here you can see this, there is a stricture formation. So the stricture has to be excised. If there is a stricture, don't compromise on that. So excise the stricture. If there is a stricture, Don't put stent and just do the shaving or desolysis. That will not do, because here the stricture always forms because the wall is involved. So otherwise, if there is a external compression, so releasing of the ureter will do. So here you can do end-to-end anastomosis, and it heals beautifully. And there will be a little bit of disparity in the lumen. You can see the proximal is much bigger than the distal. So you can use 3 to 4 sutures should be enough. And that is the segmental resection. And another case, so this is a case of, in the very close to the bladder stricture because of endometriosis. So this was referred by urologist to me. See the time how it has come. The urologists are referring patient for ureteric implantation because they are not very well with worse with the suturing. So the surgeons and urologists should learn suturing because they always depend on the devices like stapler, clips, these kind of things. So here you can see that is a stricture there. And so you dissect the thing and like at the distal segment. And rather than mobilizing the ureter excessively, you mobilize the bladder. And it is a matter of end-to-end anastomosis over the stent. It is the lumen should be as small as possible. But if the opening on the bladder is very small, you cannot see the opening. Maybe slightly bigger is better, and always start posteriorly because this you may miss if you start from anterior. So always start posterior, and do interrupted is always better than continuous, because the continuous may become loosened. Wherever there are crucial suturing is necessary, interrupted is always better, because the continuous suture, there may be possibility of loosening of the suture. And here you can see this the mesentery of the ureter and the serosa of the bladder is approximated. And bury the ureter and the stent with the bladder fold, so that that also act as a, now you can see this, we can leave at this stage only, but what I'm doing is I'm taking the serosa and bury that, so that it acts as a artificial sphincter. And absolutely there won't be any. And also always put at the fundus or the anterior lateral wall. Don't put it in the center, because if you put it in the center, the ureter has to come like this. So put it, dissect the bladder, fill it, and laterally on that side. So that is how it has to be done. So here you can see, don't bring it to the center. And so this is how it is done. And you can see the blood vessel to the ureter is preserved. This is the most important thing. So never tease the ureteric adventitia, because if you tease the ureteric adventitia, so that is the area where it undergoes necrosis. So never the ureter carries its blood supply, its own blood supply, and bladder has beautiful blood supply from this side. And and of course the second layer you can close with the barbed suture, but first layer always use interrupted suture. And of course the stent is there which will be protecting. So I think it covers all the 3 videos. And of course, ureterolysis is just the pelvic brim up to the tunnel. So you dissect in cases of deep infiltrating endometriosis. Yeah, you can stop this. Stop sharing.
Yes, sir. That was really a treat to our eyes, sir. Thank you for such wonderful videos. So I think we will be closing the session, as our session is only for 1 hour. And this subject is very vast. I don't think we can cover the entire spectrum in
Yeah,
one,
and
one
another
hour
thing
time.
is, another important point I would like to mention here is in endometriosis, pelvic floor is commonly affected because of 2 reasons. One is the involvement of the nerves, and another is the the pain, the pain spasm of the pelvic floor muscles, which causes severe pain. So you must have noticed in deep infiltrating endometriosis, patient come with abdominal pain. Then she will start every month. She will add one area to the pain: pelvic floor, vulvodynia, vestibulodynia, thigh pain, whole leg pain, backache. Like this, it will go on. So pelvic floor is a very important method wherein it has to be identified. And so in all these cases, whenever they have the pelvic floor pain, Kegel's exercise will help them a lot. Physiotherapy will help them a lot. And if they have dyspareunia and severe pain, not responding to anything, and of course they will have urinary and bowel symptoms. So Botox is a very good treatment. So we inject Botox 100 to 200 units into the obturator internus, then the vaginal muscle at 3 points you inject. So I had injected Botox for many cases of dyspareunia, and all of them had a very good relief. So here the pathology is same, like a dyspareunia, because the muscles are vaginismus. So the muscles are actively, rigorously undergoing spasm. So similar thing happens in the pelvic floor because it is very closely related to the pelvic structure, and endometriosis can traverse up to the pelvic floor. So I think all this, a team of people who manage the endometriosis should be there. Pelvic rehab, just surgery or IVF is not enough. You need a good physiotherapist. So you need a good counselor. So all these things has to be done properly and meticulously, and in endometriosis, the symptomatology more than any MRI or any CT or anything, the symptomatology is the most important thing. So you have to treat the patient for what she is coming. So suppose if she is coming for infertility, and if you do colonic resection, what is the use of that surgery? She want a baby. So you want their infertility becomes the thing. And also if the patient has urinary or bowel problems, that surgery becomes important. So thus analyzing the symptomatology and the relief of the pelvic pain is the most important thing in endometriosis, rather than anything else. I believe what the patient is saying.
So
So we
there
have
is a
two
question.
questions.
There is a
Everybody
question:
has
how to
gone
prevent
into
Questions from the
stricture of
audience. Yeah.
ureter
this mode.
by Dr. Gangambika. As the previous panelists have mentioned, the complete excision
What
of the
happened?
lesion is very important, and the prior pre-op placement of the ureteric stents is another very important precaution. And the third thing is the
Other
proper
methods.
end-to-end anastomosis has to be done. These are the three, some of the measures which has to be taken. Any inputs from other panelists?
Switch off idea.
No, I think you have already summed
Oh,
it
the
up
power has
quite well.
gone.
Hello.
Yes, yes, you are
Yes,
audible.
Yeah,
You are audible.
yeah. So I think you have summed it quite well. Proper diagnosis and index of suspicion should be, because this is not something which is. I mean, most of the times it is a misdiagnosis, and it will most of the times come in an advanced stages. So an index of suspicion is important. Always image the kidneys. Either you do an ultrasound or a CT or anything. In every case of endometriosis, so that suspicion should be there. And wherever it is possible, most of the times excision is the primary mode of treatment for any urological endometriosis. And reconstruction also plays an important role in the urological tract. So be it a ureteric reanastomosis or a ureteric reimplant or a bladder surgery, tension-free, good mobilization, use of delayed absorbable stitches is something which is important. And like Dr. Ramesh also touched upon the involvement of nerves and the importance of physiotherapy and Botox. So that also, and absolutely a multidisciplinary team is something which is important, because and it should be tailored to the patient. Like sir has rightly said, you should treat the symptoms what somebody has, uh, and uh, and just don't do a surgery because you are capable of doing it.
So we have one more question. Should we take that?
Yeah,
So,
please.
yeah, there is post-op suppression is done with what drugs, dose and duration, and follow-up. And they also want to know Botox, where
Ramesh
is
sir,
it injected?
unmute sir.
Ramesh sir, unmute, please.
Yeah, please tell me.
There is a question from the audience. Post-op suppression is done with what drugs, dose,
Post-op?
and post-op suppression.
Signal. I think there is a signal problem.
Yeah, actually, see, since if there is any the urinary tract involvement of endometriosis, especially the ureteric
Sorry, there is a
involvement,
disturbance in
we
the
straight away consider it as a deep infiltrating
ಮೊದಲೇ
endometriosis.
charge ಮಾಡಿಡು.
And the deep infiltrating endometriosis, if there is partial surgery, partial correction of
ಮೊದಲು
it,
ಆಚೆ ತಗೊಂಡಾಗ ಏನಾರ ಬರುತ್ತೆ.
then definitely they will not respond to the post-op the medical therapy. So the only best remedy is that we should completely excise the lesion, and we should not depend it on the post-op the medical therapy. It will not respond in cases of deep infiltrating endometriosis. The post-op medical therapy like the elagolix or the dynogest will be useful only in cases where there is left out endometriosis, endometriotic lesions. Apart from that, the ureteric, the endometriosis better be completely excised and rely less on the post-op any of the medical therapy.
So there is no need to give post-op to prevent recurrence, sir? Is there any role of giving medical therapy like how we have discussed 6 months?
Yeah, so in a situation, I think suppression, sir, as Dr. Vijay Kumar has already said, it's like a deep infiltrating endometriosis. So excision is primarily the key. That's the majority treatment. And then you give some form of progesterone. We commonly give Dynogest for somewhere up to 6 months to prevent a recurrence.
Yeah, thank you, sir. So, yeah, I think this vast subject was discussed in a
Yes.
very crisp and most of the aspects of deep infiltrating endometriosis were discussed today. So, my sincere gratitude and thanks to all the panelists who have made this disease. It has created awareness among all of us. Like, how do we, proceed with a silent disease like ureteric endometriosis? So, thank you, Ranade sir, and I think Ramesh sir is logged out, sir. Thank you, Vijay sir, and thanks for such a wonderful opportunity. At the end, would anyone of you like to give 2, 3 take-home points for our audience?
I think, as I said, diagnosis is something important. So everybody should have an index of suspicion. Proper imaging is important. Surgery is the key majority of the times, and reconstruction also should play a role. Post-operative care is also important. Pre-operative planning is also important, and it's also important that in a situation where you are not trained to do a ureteric reimplant or not trained, you can always involve a urologist. There is no harm in taking help. But always do what is best for the patient. Just do avoid. I mean, there's no point in avoiding and leaving endometriosis inside and just excising and leaving majority of the disease inside. It will not solve the problem. So that is something which is important to be done.
Yes.
And again, post-op suppression is important.
Aarti, I think the connection was lost.
Yes, yes,
I
sir.
think there was a
Your
question
take-home
for
message,
me.
sir.
What was the question?
Your take-home message.
message for the delegates.
Your
Take-home message. Take-home message for the delegates, sir. What do you want to tell? Yes, sir.
Message. See, now the new generation, I am very, very sad to say that whenever the patient comes, they don't take the history, they don't do the examination. symptomatology in endometriosis, I will tell you, nothing is as important as symptomatology. So you are treating the MRI report or an ultrasound thing, which is a very stupid thing. So first ask her what is first 5 minutes should be history only. So history is the most important thing. So first let them keep the MRI ultrasound report aside, and patients also have become like that. Sir, see, I have got endometriosis. So that is very important. And also, like the an ultrasound or MRI, you can the ovarian cyst, the presence of ovarian cyst. Most of the people can operate. Most of the laparoscopic surgeons can operate. And also now we are labeled as pelvic scopic surgeons. See, now suppose every day if we are doing endometriosis cases, then both the ureter and rectum has to be dealt. Then you have to marry one gastroenterologist and one urologist. So that is impossible. So it is very difficult to this thing, and they will come and complicate the things because the endometriosis is our field, and we have a better information about it. Not that their field is different. And also now as a pelviscopic surgeons, it is allowed as per the law, even if there is a litigation or anything thing. Colonic injury is the commonest complication which can produce problems. And also whoever specializes in endometriosis has to know very good aspect of infertility and IVF. If you are just operating on every endometriosis, you can be called as endometriosis technician. That's all, OT technician. You cannot be an infertility specialist. For example, if there is deep infiltrating endometriosis and AMH is low, antral count is less, she has to directly go for IVF. And this is one of the initially when I used to do a lot of endometriosis, and after the surgery they used to disappear. So most of the people, you know where they are going. They are going to IVF specialist. So you don't have the follow. Let them go and take the treatment. That is different. But they are going somewhere means they are not happy with your treatment. Especially in cases of symptomatology is important. When to operate and when not to operate is the important thing. The presence of endometrioma is important indication for surgery. Bilateral endometrioma surgery is not the option. Egg freezing or embryo freezing is the option. Don't do bilateral cystectomy.
5 minutes.
Bilateral
We'll
cystectomy.
conclude
Do egg
matter.
freezing or embryo freezing. And not all endometriosis needs to be operated. So suppose
Yes, to add to it, so according to my experience, I have seen the most of the time we will start doing surgery in a cases of simple endometriosis. We will be thinking that there are endometrioma, ovarian endometrioma, or bilateral ovarian endometrioma, but we should make it sure that we always do the wide dissection. Not to forget that we should also do proper ureterolysis so that the complete excision of the lesion is done.
yes, no, there is no doubt
Sometimes
about
what
it.
happens, we will be halfly prepared. We will not be well prepared for the taking up of the case. So this has to be prevented, and we have to properly counsel the patient, and we should go for more aggressive surgical management if at all we are doing the surgical management.
First of all, you may be doing a beautiful surgery, complete removal. That may not be necessary for the patient. So to choose the patient whom to operate and when not to operate, when to do the medical treatment, when to do the IVF treatment, when to do the hysterectomy, all this should be very clear. So unless we understand this points, so we are not doing justice. We may do very beautiful surgery, but for a wrong indication. So that is where the comes where like now the new understanding has to come in endometriosis, that because if both the endometriosis specialist, surgeon and IVF specialist sit side by side or form a team, laparoscopic surgeon will say, I will do the surgery. IVF will say, no, IVF is better. So then again, it will be like a panel discussion. If the one person can do both the things, so I think consciously, he will be the correct person to decide whether to do the surgery or not for this patient, whether to do IVF or not, whether to do the hysterectomy, whether to do the rectal resection. So many times we see the patient has come with for IVF or infertility, you do the rectal resection, and what is the use of such a treatment? So the discretion. So the discretion of the selecting the case is very, very important rather than the surgery itself. So even if you are 10% lesser in surgery, what cases you select, and your extensive knowledge about the drugs used in endometriosis, and when to use what drug, and also the pain management is very, very important. And after 40, and if the fertility is not this thing, so do radical, that means hysterectomy, why she is suffering. So these are all the things which one has to understand. And so I think there are a lot more things to be told. These are the most important things.
Thank you, sir.
Yes, sir. So thank you very much, sir. It was a wonderful insights. Thank you for stripping away the complexity of this frozen pelvis and sharing us all your surgical nuisances.
Yeah. Thank you so much
So,
for giving this opportunity to
yes,
interact with this thing. I hope we had a good audience. I
yes.
don't know whether there were good audience or not.
So
Thank you, Dr.
this will
Aarti,
be
for
recorded on YouTube, sir, and
Uh,
everybody can
you can put
utilize.
on YouTube.
Yes, sir. This has
Uh,
been recorded, sir.
yeah. And
So
also, whoever want to specialize in endometriosis, not only surgery, you work with IVF unit so that you will understand better. Whatever the wrongdoings, they can tell you what wrong we are doing on infertile patient.
thank you, sir.
Yeah.
thank you, sir. Thank you,
Thank
Dr.
you.
Thank you,
Aarti,
Thank you.
for
Ranade,
Thank you.
sir.
moderating.
Thank you,
Thank you,
Ranade, sir.
Dr. Rohit.
Thank you.
Bye.
Yeah, thank you, Vijay,
Oh,
sir.
yeah. Rohit, nice to see you. This is the first time I think we are
Thank you.
having interaction. So I've
Yes,
heard
sir.
many things good about your dissection, etc. So very
Thank you.
nice
Thank
to
you.
have a youngster in Bangalore society.
Thank you. Thank you, sir.
Dr. Rohit, I am Dr. Sridhara's wife, surgical
Yeah.
guest.
Oh,
So,
hello.